Okay, thanks as always for listening to the Foot and Ankle Orthopedic Surgeon. Today's episode is on Liz Watson, the Australian Diamonds netball captain, who's unfortunately had to have surgery for a navicular bone injury. We're going to go in what the possibilities of this injury might be and why she's needed to have the surgery. So the recent articles in the newspapers have said that she had surgery on her foot recently on Wednesday after suffering a navicular bone injury, and she'd be unavailable for the season. It also said she's managed this injury throughout her career, which meaning it's been a long-standing problem, not something that she necessarily suffered recently. So that really breaks down to two main possibilities of why she might be needing surgery. The first diagnosis is something called a navicular stress fracture, which is a type of fracture in your foot. And here we have it here. It's actually that black line in the photo there, and we're going to point that out for you very shortly. So that's it just here. And then the other one's called an accessory navicular, which is a little extra bit of bone in the navicular bone, which is a bone in your foot, and we're going to point that out here for you too. So that's just that little pocket of bone just there in the foot. So we're going to go into each of these two injuries in depth. We're going to start with the stress fracture. So in terms of what is a stress fracture, certainly orthopedic textbooks say it's something called a result of microscopic injuries where the bone is subjected to submaximal stress. That's pretty hard to understand. It's a lot of medical jargon. We're going to try and break it down for you so it's a bit easier to understand. So what a stress fracture is essentially is an injury that you can't see easily on an x-ray. It keeps happening over and over to weaken the bone, but doesn't have enough force to crack it completely and break it into two pieces. So it's this sort of indolent thing that keeps going on and on but doesn't heal. So in terms of what the navicular is itself, it's a bone in the foot. It looks like a horseshoe, just like I'm drawing here. In the foot, we're going to label it for you. This is looking at your foot from the top down. And that's hit there, it's the navicular there. And next to the navicular is a bone called the talus. The talus actually makes up part of your ankle and then heads into the foot. And it forms a joint with the navicular so that it can move. And that's the talus here in the x-ray right next to the navicular. And the talo-navicular joint between the two actually provides an enormous amount of movement in your foot. It's very important. Now this is what your foot looks like in an x-ray taken from the side. We're going to label the bones. We already labelled the tibia for you there. We're going to label the heel bone known as the calcaneus. We're going to mark out the ankle just here. That's the ankle joint. The ankle joint is made up by the tibia and also this bone that looks like a peanut here called the talus, which we were talking about on the other slide. And then we're going to draw the navicular just here. It's what that bone there in the middle of the red circle. That's it just there. And that's what the navicular looks like when looking at it from the side on an x-ray. Now, in terms of symptoms, if you've got this navicular stress fracture, then it's pretty weird. It's what we call poorly localized, so it can really be anywhere around the top of the foot, in the middle of the foot. Poorly localized just means you can't really point with it to a finger. You sort of talk about an area rather than a specific spot. It's usually worse with push-off activities, so that means that things like netball are really going to aggravate it, but other activities like running and jumping certainly will do it. And the average delay to diagnosis in these type of injuries is about 4 months. That's because the x-ray is usually pretty normal, the pain's pretty non-specific, so it can be difficult to pick up. Now we always start with a weight-bearing x-ray because it will show about 30% of injuries, but in the majority of cases, unfortunately, it's going to be normal. So the x-ray actually misses the diagnosis in about 60%. And we're at 66%, I should correct myself. I've actually labelled the navicular there. That one's not broken, it's a normal x-ray. So there are different types of navicular stress fractures, and some are bad, some are not so bad, but in general they take a long time to heal. Now we're going to draw a navicular again. This horseshoe picture that we were talking about is what the navicular looks like if you were looking from at the foot from the top, like the eyes are looking just there, okay? When we actually talk of types of navicular fracture, it actually talks about what the navicular looks like when you look at it from the front. So we're just going to draw an arrow here, and that's the direction we're looking at the foot from now. And that nice horseshoe that we've drawn just here, it actually looks sort of like an oblong-y, oval-y type shape, which we're going to draw just here when you look at it from the front. And this is the picture that we're looking at the types of navicular fracture in. Okay, so this is what they're going to look like. Now, usually we're picking these up on an MRI, not an X-ray. A type 1 fracture, which is the least bad, essentially, it's just a little crack in the top of the navicular in an area called the cortex. It's pretty small, looks pretty minor. Now, a type 2 actually heads further into the navicular, so it cracks the top and sort of heads into the middle of the navicular, but the bone hasn't really broken into two pieces. The type 3 fracture, which is the worst, actually breaks the fracture into more than one piece. So what happens is that it goes all the way through and can be two pieces or more. Now, you can see here from what I'm writing on the bottom is that these injuries take a long time to get over. Even a type 1 takes 3 months to recover, a type 2 is 3 to 6 months, and a type 3 is 6 to 8 months. So that's, a lot of time, right? And probably Liz Watson has a type 1 or type 2. And on average, athletes or people that play sport lose 1 season of sport. So that's fitting with what Liz Watson has said. She's taking the season off, although she is having surgery. Now, the general treatment for these injuries, if you rock into my office with it, initially is to put you into a plaster and keep you off it into something called a short leg plaster of Paris. And the reason for that is to give the bone a rest, to stop irritating it and give it a chance to heal. But it usually means you're in a plaster for a total of 6 weeks, and then we usually say you need to rest and stop doing any provoking activities such as netball, running, sport, jumping, that sort of thing, afterwards for a period of time. And that usually fixes people, usually resolves in about 96% of patients after that period of time, which is a lot, which is really good, right? The problem with that is there is actually still a chance of refracture. So about 1 in 10 patients, even 5 years after the injury, have a recurrence of the problem. So it's difficult to treat, right? And especially in someone who has high performance as Liz Watson, it's going to be really challenging. So what if the plaster doesn't work? Well, unfortunately, then you're looking at surgery, and that means fixation. That may be what's happened to Liz Watson. It usually means a screw or something just like this, with the idea to try and provoke the bone to heal and give it a bit more stability. Now, the other problem that we were talking about before at the beginning of the video is the accessory navicular. That could be the other reason why she's needed surgery, and that's that little dotted bone there next to the horseshoe area, and that's a genetic variant, unfortunately. Now, if that was the case, Liz has probably had that most of her life, and it may not have been symptomatic potentially to her teenage years or when she really started high-performance netball. It probably improves with some rest in the off-season, and she may have actually tried a period in plaster to try and get it to calm down. Now, the reason for putting these x-rays up is to actually show there's a tendon that attaches to that accessory navicular called the tibialis posterior tendon, and that's what it looks like. Sort of, obviously it's not red, but it just gives you an idea where it goes and where it attaches into. And that's responsible for holding up your arch, and that can certainly be irritated in this type of problem. Now, if you have surgery to have that piece of bone taken out, then you then have to take out the tendon and reattach it into the navicular, and usually what's called is advanced. So that's just what that x-ray is just showing there. But I would say that has a variable return to sport in an athlete, and it's possible if she has this problem and she has a really flat foot, that she may need other parts with the surgery as well, which is a bit more complex. So in patients that have a heel that's really pointing out, and that's not in the picture here, but if you had a patient with a heel pointed way more out towards the arrow, you may need to actually break the heel to bring it more towards the middle, and sometimes you need to borrow another tendon to help hold up the arch. Now, hopefully that's not what Liz Watson's case is, but it's possible. So very complex. Hopefully she makes it back within a season, but thank you for listening to me. Please visit www.footnavicular.com.au and subscribe to our videos if you like this video. We always put this disclaimer at the end of our video, just so you know. Look, the opinions here, I don't know Liz Watson. I don't know any of the teams that she's involved in, including the Melbourne Vixens, but I'm just speculating off the news articles that I've seen as to what her injury might be, because those are the 2 most common problems that you see, but I don't have any relationships with the team or Liz Watson herself, and hence if you feel like you've got a similar problem, I would advise you to see your own doctor. Please do not use this as medical advice to treat yourself. But thank you once again for listening to our videos, and see you next time.